I'm Dr. Ken Landau. Thanks for watching. Let's talk about Takasubo Cardiomyopathy. This is the syndrome of the broken heart. It's also called stress-induced cardiomyopathy. It's what happens when you can't deal with the emotion or the physical stress that's thrust upon you. All of a sudden it seems that the heart muscle itself doesn't work right. You develop a stress-induced cardiomyopathy. Or medically we call it the left ventricle, that's the major pumping chamber of the heart, left ventricular apical ballooning syndrome. The apex is the part closest to your abdomen. And when the apex of the heart, instead of contracting as it normally should to push the blood forward, now it fills up like a balloon when the top part of the heart is trying to contract. And that obviously leads to a variety of symptoms, and the symptoms are exactly the same as a heart attack. So you rush to the hospital, you have the symptoms of a heart attack. Electrocardiogram shows you had a heart attack. But you get to the catheterization laboratory and they can't find any clot, they can't find any narrowing, they can't find any coronary artery disease. First case was reported here in the United States, 1986. It was a woman whose son had just committed suicide. She had those same kind of symptoms. She had the symptoms of a heart attack, but when she was examined, nothing wrong with her coronary arteries, but she did have the ballooning out of the bottom part, the apex of her heart. Well, nobody thought much of it. It was only a single case report. Then, starting in the 1990s, reported with increasing frequency in Japan, but in Japanese. And as a result, didn't make it to the American Journals of Cardiology, but then translated into our journals starting in around the year 2000. And it was recognized it's not such an uncommon condition. When the heart contracts, it balloons out at the bottom. And that's what Takasubo means. It actually is the name of a pot that Japanese fishermen use to trap the octopus. And that's what the heart looks like when the heart tries to contract. And it balloons out at the bottom. Well, typically it's considered a benign condition. And the majority of people do indeed recover. The likelihood of having the condition, well, probably about 50,000 minimum people have the condition every year. On the other hand, it may well be significantly more than that because it's underreported. It was thought to be benign originally, but it seems to be associated with somewhere between 7,000 and 14,000 deaths a year because of the condition. So it isn't so benign and actually has the same short-term prognosis as a heart attack or acute coronary syndrome. When you rush to the hospital, because the standard heart attack is associated with arteriosclerosis, narrowing of the vessels because of all the debris, the atheroma, the plaque that's developed over the course of the years, that's what people think of. So you're sort of shunted down in that direction. But on the other hand, there are other things that can cause the same kind of symptoms. So it could be a heart attack, or it could be vasospastic angina, could be a pheochromocytoma, which is a tumor on the adrenal gland that produces too much adrenaline, and could be a myocarditis, inflammation of the heart because of a virus or because of some other kind of a disease. Maybe it's due to decompensated heart failure or tachycardia, ventricular tachycardia. Maybe it has something to do with the arteries not being just on the surface of the heart where they're supposed to be, but dip into the muscular wall so that when the heart contracts, it squeezes off the artery, and then you have the symptoms. Well, all of those things have to be considered. So it's estimated that maybe as many as 2 or 3 or 4% of the people who present with acute myocardial infarction or the symptoms of acute myocardial infarction actually have this syndrome, especially if they happen to be women. Well, about 80% of the people are over age 50, and 90% of the people are women who have the condition. And if we look at women over age 55, it's 11 times more common in those women than it is in men similarly aged. And if we look at women who are less than 55, it's still 5 times more common than it is in men. Men at a younger age tend to get the condition, oftentimes because of some kind of drug, like marijuana, THC, or the synthetic cannabinoids. Seems that especially in the postmenopausal women, it has to do with endothelial dysfunction. Those are the cells that line the arteries. And there's something wrong with them. They're extra responsive to some hormones. Well, the hormone obviously seems to be something to do with estrogen because it's after the menopause. So it may well be an increased level of oxidative stress or more anxiety or depression or sleep problems. Or it may be that after the menopause, neuropeptide Y, NPY, well, that seems to be increased. And it seems that that NPY that we all think of as a regulator of appetite actually also causes vasoconstriction, narrowing of the vessels. And it seems that that is one of the factors involved in this condition. And for whatever reason, it's more commonly diagnosed in California, say, than it is in Massachusetts or in the Midwest. The stressors, they tend to be negative stressors. It's either a physical stress or an emotional stress. And it could range anywhere from death of a loved one to a natural disaster to financial loss or a motor vehicle accident or a fall or surgery or receiving bad news, diagnosis of cancer, domestic violence or an asthma attack or a stroke or an argument with someone, severe pain or a sudden drop in the blood pressure. And men, not infrequently related to the synthetic cannabinoids, the marijuana, the spice, seem to do something to the heart vessels. And it may be that it just pushes up the NPY, the neuropeptide Y, and the adrenaline. Also seems to be associated with methamphetamine use and cocaine use, especially in men. Withdrawal from drugs or alcohol. Seems that those procedures that you can have done that increase the surge of the hormones seems to be associated with the condition. Now, on the other hand, you can develop what's known as the happy heart syndrome. So it could be good news in some cases, and that could lead you to the problem. So in men, it seems to be more physical trigger. Women seems to be more emotional trigger. But in about 30% of the people, we can't figure out why the condition develops. The symptoms, they mimic exactly what they would be if you had a heart attack. You get the chest pain that's characteristic of angina. In about 3/4 of the individuals tends to occur after a severe emotional stress. But severe is different to different people, of course. Shortness of breath occurs in about half of the people. Sometimes seems that some of the fluid develops inside the lung because the heart doesn't work so well. Dizziness in about 1/4 of the people. Syncope, fainting. Pain radiating, yes, to the left arm, but also to the right arm. Most people have normal blood pressure. Some people don't even have any symptoms at all, often associated with anxiety and depression. Sometimes you can develop some complications, unusual problems like cardiac arrest or cardiac shock, cardiogenic shock, serious ventricular arrhythmias. People have respiratory distress. They're short of breath. They have crackles in the lung when the doctor listens with a stethoscope, and have a heart murmur that suggests an ejection murmur, or the murmur of mitral regurgitation. Mitral regurgitation is what happens when the valve between the left atrium and the left ventricle doesn't work right, and it opens too much. And the reason it opens too much is because when the heart balloons out, the mitral valve is pulled forward, and as it's pulled forward, now it allows some of the fluid, some of the blood, to go backward in the wrong direction. People tend to have normal heart rate. They tend to have blood pressure that's normal or low, narrowed pulse pressure instead of being 40, so 120/80. If we subtract one from the other, we get 40. Well, the number is narrower in Takasubo Cardiomyopathy. Skin tends to be cold to the touch, principally because in this condition you have so much of the adrenaline floating around, it's constricted the vessels. You have a sinus tachycardia, heart's beating faster than normal, some premature beats thrown in. Sometimes you have dysfunction of the sinus node. That's where the electrical impulses that control the heart rate originate. Maybe atrial fibrillation in some people. Maybe arrhythmias that seem to originate in different parts of the heart. We find that the blood doesn't flow very well, and as the blood is relatively stagnant, you might form a clot in the left ventricle, the main pumping chamber of the heart, that occurs maybe somewhere between 2 and 5 days after the symptoms occur. And when you have that clot that forms, sometimes the clot can have little pieces that break off and spread through the blood and are pushed to the brain. You might have a stroke. Pushed to other areas, you might have complications wherever the thromboembolism happens to end. People develop some pulmonary edema, fluid in the lungs. They can develop some problem with the left ventricular outflow. They develop an obstruction when the wall that separates the left ventricle and the right ventricle tends to bulge into the area where the aortic valve should be. The aortic valve area is where, when the ventricle contracts, the blood's supposed to go through the aortic valve into the aorta and into the brain, into the arms, into the lung, to the liver, and to other organs of the body. Well, the ejection fraction tends to be relatively low, just like it is in heart failure. So it could be down 45% or less. And then we have the septum in between the right and the left ventricle tends to become edematous, tends to become swollen, and then it tends to be pushed over toward the aortic valve. That's what causes the problem. And with the mitral regurgitation to boot, now the blood isn't going to the areas it's supposed to go to. And that could lead to cardiogenic shock. So we have a series of complications that can occur just because you were in physical pain or emotional stress. Now, sometimes people talk about primary type and secondary type. The primary type has more chest pain, more vegetative symptoms. These people are more likely to have blood clots that develop, and they tend to be more anxious. The secondary type have more palpitations and syncope and heart failure, longer stay in the hospital, and actually more damage to the heart when we check the biomarkers, the substances in the blood that give us a guide as to how much damage was done to the heart. Now, interestingly, sometimes you can get exactly the same kind of symptoms after a stroke, a hemorrhagic stroke, not the kind of stroke you get when you have narrowing of your carotid arteries, and not the kind you get if you have atrial fibrillation and a piece of the clot goes to your brain. But this occurs with bleeding into the interior portion of the brain itself. That's what we call subarachnoid hemorrhage or ischemic stroke. And that seems to be associated with the same kind of symptoms as we would have with Takasubo Cardiomyopathy. Interesting again, diabetes. Well, if a person is relatively young, less than age 60, with diabetes, they're more likely to develop the Takasubo Cardiomyopathy than if they're older and have diabetes. Why? Well, when they're younger, they have endothelial dysfunction. Remember those cells lining the vessels? But when they get older, they have the neuropathy that goes along with the diabetes. And it's not just of your hands and your feet, but it's also autonomic neuropathy that involves the interior of your body. And that means that those areas are not as receptive inside the heart to the production of the adrenaline. And another interesting finding is with this condition, we find that there seems to be an increased incidence of cancer, maybe up to about 10%, average anywhere between 4% and 24%. The cancer is diagnosed either a couple years before or a couple years after the diagnosis of the Takasubo Cardiomyopathy. We don't exactly know what the correlation is, but it's just something that's found. So the diagnosis is made when you get to the hospital, the history and physical, same thing as a heart attack. The electrocardiogram is the same thing as a heart attack. Laboratory findings, we need the echocardiogram or the angiogram or the MRI in order to make the diagnosis, because this is one of those occult conditions. Occult condition. It doesn't have any special manifestations other than you have the stress, but everybody has stress. So how do we determine how much stress was enough to get this condition? And once you get the condition once, it has a tendency to come back about 2% per year. So after 4 or 5 years, likelihood around 10%. Average age for recurrence around 66. How to make the diagnosis? Well, that's really tough to do unless you have the echocardiogram or unless you have the angiogram. They tried it at the Mayo Clinic in 2004, 2008, then Hopkins in 2012, and in Sweden in 2013, and the European Society of Cardiology in 2015 to come up with a diagnosis, or at least some sort of guidelines. So we have transient abnormality. Transient means temporary abnormality of the constriction mechanisms, where we balloon out some part of the heart, typically the apex, the bottom part of the heart closest to the diaphragm. And then we should have some increase in the biomarkers, those chemicals like the troponins and the CKMBs, the creatine kinase, myocardial band, and the B natriuretic peptide. Those are all elevated. They give us a good chance, whether it's muscle damage itself or stretch-related damage that we would find more in a heart failure. Electrocardiogram shows ST elevation, shows us after a day or two, some T-wave inversion, some new bundle branch block sometime. Coronary angiogram shows that you don't have any significant stenosis, no plaque, no spasm, no rupture. Well, we have all of that. And then we exclude the pheochromocytoma. Pheochromocytoma has to be excluded because that can cause exactly the same kind of symptoms. Now, the syndrome itself can have different manifestations depending on which part of the heart seems to balloon out. And for the most part, it's the bottom part, what we call the apex of the heart. That's 80% of the time. That's the typical condition. Now, it doesn't necessarily have to be the bottom part. It could be the top part, what we call the base of the heart. That's unusual. Sometimes it's the central part of the heart. Sometimes it's two of the three areas of the heart that seem to balloon out. Well, if it happens to be the inverted form, where it's the top part that's ballooning out, that's more in younger individuals, more in men than it is women, more often associated with that bleeding into the brain we call the subarachnoid hemorrhage. Those people tend to have the worst prognosis. Now, it's thought to be principally a condition that involves the left ventricle, the major pumping chamber of the heart, the biggest one. But it also, anywhere between 35 and 50%, involves the other side of the heart, involves the right part of the heart. And we think that the basic problem underlying all of this is an abnormality in the energy production within the heart. We find that there's an abnormal ratio of the phosphocreatine to the ATP. That's ATP for the generation of the energy in the heart. We find that there's an abnormal calcium uptake into the heart muscle cells themselves. We find that sometimes there's activation of some of those white blood cells that happen to be in the heart, called monocytes, and those monocytes seem to produce a variety of cytokines. And those cytokines are inflammatory in their activity. So we actually get inflammation in the heart. We get a sterile inflammation. And then we seem to have some involvement in different areas of the brain. After all, it's an emotion, it's a stress. That activates somehow the hypothalamic, pituitary, adrenal axis. And then we get all the adrenaline, and we get all the norepinephrine, and it seems that there might even be a genetic component to the whole story. Genetic component that's commonly found, at least in Japan. Rate of recurrence is higher in these individuals. So we have a mismatch of the ability of the heart to pump and the blood flowing to the heart. So we have endothelial dysfunction, and that is another major component. And then all of this causes those biomarkers to increase, shows the damage to the heart muscle itself, the damage associated with a heart attack or the damage associated with the heart failure, but the troponins are increased and the creatine kinase MB band is increased. Some other things that are increased that make us think that, oh my goodness, there's significant heart damage. But all of a sudden, after a period of 1 to 4 weeks, it seems that the people do remarkably well. When they get to the hospital, they're treated acutely, managed quite well for the overwhelming majority of people with some time, some oxygen, some other simple in-hospital therapies that are routine. And then what do we do with the person when the person's discharged? It's a beta blocker. That's very commonly used, but doesn't seem to prevent the recurrences. Used to be popular several years ago, less popular now. Now the most popular medicines are either the ACE inhibitors or the angiotensin receptor blockers. Those are the common medicines that we use to treat high blood pressure. Seems that they're associated with a decrease in the one-year mortality and a decrease in the incidence of recurrence. Sometimes people are given diuretics, and sometimes they're given aspirin therapy to help prevent clotting. The idea about giving them a clopidogrel, probably the overwhelming majority don't. They don't need them. Estrogen, well, seems that a small study suggests that you can have decreased recurrence in women who are given estrogen as opposed to the hormone replacement therapy with the progesterone in addition. The suggestion of problems that develop, increased mortality, if you're older, over age 70, if you have a physical trigger as opposed to an emotional trigger, if you're a man, if you suffer from cardiac arrest, if you have an ischemic stroke, you have some other kind of neurologic or psychiatric disease, if your ejection fraction is really low or you have respiratory failure, then unfortunately you have a higher chance of dying. But overall, it seems that this condition, once considered rare, is not so rare. Once considered benign, is not so benign. That's the story about Takasubo Cardiomyopathy. Broken heart, it's a real medical disease. And it comes on after either severe physical or mental stress. It seems that the adrenaline-related compounds stun the heart, interfere with the normal contraction. Symptoms just the same as a heart attack, but the territory involved in the heart is more than just one single coronary artery. It doesn't seem that coronary artery disease explains this condition at all. It's not related. Takotsubo cardiomyopathy can occur in maybe as many as 2 to 4% of all heart attacks. But unfortunately, it often goes undiagnosed and unrecognized. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.